Good evening, and thank you for joining us. Thank you to the organizers for the invitation. I'm excited to share with you updates in cardiac MRI and the value of advanced imaging in the contemporary care of the cancer patient. I will briefly highlight the value of accurate EF assessment during cancer therapy, followed by how we approach the evaluation of a cardiac mass, and would like to spend the remainder of the evening focusing on how a comprehensive evaluation gives us key insight into the cause of cardiotoxicity, especially with the rapidly evolving field of cancer therapeutics. Here's a typical CMR protocol for the standard cancer patient. We start with structure and functional assessment, including volumetric assessment of ejection fraction, followed by tissue characterization with native T1 and T2 mapping. Contrast is then delivered, immediately after which a thrombus sequence is employed, followed by late gadolinium enhancement imaging, as well as post-contrast T1 imaging, which is used to evaluate extracellular volume. Additional sequences, depending on the clinical scenario, include evaluation for constriction, valvular regurgitation, iron deposition, or further assessment of cardiac masses, as well as an ischemic evaluation with typically adenosine vasodilator stress perfusion imaging to evaluate for ischemic heart disease. Here is a brief primer on parametric mapping and late gadolinium enhancement. Gadolinium is an extracellular, extravascular contrast agent, and late gadolinium enhancement is a result of regional differences in myocardial extracellular volume and different uptake and washout patterns within the extracellular space. This is seen in the bottom row and is most commonly referred to as replacement fibrosis, although enhancement can be seen in myocardial injury or myocyte necrosis, myocardial edema, or myocardial scar tissue. When the process is more diffuse, whether it be reactive interstitial fibrosis or an infiltrative interstitial fibrotic process, like in the middle rows, visual discrimination can be challenging, and hence why parametric mapping has found a valuable role in evaluation in these patients. T1 mapping, both pre- and post-contrast, along with a recent hematocrit, can allow us to calculate the extracellular volume, normal which is usually less than 30%, and this gives us another tool to evaluate pathology and tissue characteristics in patients. When approaching an elevated T1 mapping, or extracellular volume, the three areas as reviewed which can cause elevation is a diffuse interstitial fibrotic process, such as seen with anthracyclines, an infiltrative interstitial process, as seen in amyloidosis, or myocardial edema, which is where T2 mapping helps us, as elevations in those sequences is most associated with increased water content or edema. I next want to highlight the importance of accurate systolic function assessment in our cancer patients, especially those undergoing routine surveillance imaging, as the goal is always to minimize interruptions in care. Cardiac MRI is the gold standard for biventricular volumetric assessment of ejection fraction, especially of the right ventricle. Current guidelines recommend a cardiac MRI or nuclear MUGA scan for those individuals where echo images are suboptimal. These images can be acquired without contrast, with a cost similar to that of a transthoracic echocardiogram. When assessing the accuracy of MUGA scans compared to cardiac MRI, a recent study highlighted that MUGA scans misclassified 26 of 75 studies. Two examples to the right include a MUGA LVEF of 47%, which was quantified as 56% by cardiac MRI, followed by another MUGA scan with an EF of 69%, which was actually quantified as an EF of 44% by CMR, highlighting again the need for accurate assessment of ejection fraction, so we are not treating a number, but treating the patient instead. Another important consideration, especially in cancer patients, to note is that a decline in LV ejection fraction or strain can be for two reasons: either a drop in LV end diastolic volume or an increase in end systolic volume. Example on the left with case A shows a cancer patient with an EF drop from 63% to 52%, but this was driven by a drop in LV end diastolic volume and had been known to have increased vomiting and diarrhea, suggesting a hypovolemic state. Compared to the right, an EF declined from 61% to 49%, which was due to a true increase in end systolic volume, and for which the patient was correctly started on cardioprotective therapy. Here is a recent example of a metastatic breast cancer patient on Trastuzumab, whose therapy was placed on hold after a screening echo showed an LVEF decline from 60% to 45%. She was asymptomatic, and we proceeded with a cardiac MRI, which visually showed normal biventricular function, and whose quantified volumetric EF came out to 63%, and she was restarted on therapy with no additional medicines added. Next, I want to walk you through the cardiac mass evaluation by cardiac MRI and how newer techniques are moving us closer towards a non-invasive tissue biopsy. Traditional cardiac mass evaluation began with size and location, followed by site of attachment or infiltration to the surrounding tissue. This was complemented by tissue characteristics with traditional T1 and T2 weighted imaging, which helped us discriminate the content of fat versus water. And this was followed by contrast administration that allowed us to evaluate for thrombus, followed by how vascular the mass was. We are now starting to incorporate parametric mapping techniques into mass evaluation as well. These are some highlight examples of a low T1 map signal in the top row, consistent with mitral annular calcification. The middle row shows a mass in the right atrium with intermediate T1 map characteristics consistent with thrombus, and the bottom row not well delineated on the traditional imaging, but on T1 mapping showing us low T1 map signals within the myocardium itself, consistent with metastatic melanoma, as melanin has been shown to lower T1 times. Let's walk through two recent case examples of a cardiac mass evaluation in patients with breast cancer. In the top row, we see a hyperintense mass on Cine images overlying the right atrium. On T1 weighted imaging, that mass is isointense compared to the myocardial tissue and is not suppressed by fat saturation. The signal on T1 mapping is bright and elevated. And after contrast, there's no evidence of uptake or vascularity, and there's no enhancement on LGE imaging. These characteristics are consistent with a pericardial cyst. In the bottom row, we see another large mass within the interatrial septum, which is hyperintense on T1 weighted imaging compared to the myocardial tissue, and is suppressed by fat saturation sequence, as well as a low T1 signal on mapping imaging. There is no uptake on first pass perfusion or enhancement, suggesting lack of vascularity. And these imaging findings are consistent with massive lipomatous hypertrophy. Both of these patients were continued on their breast cancer therapy with conservative management of their masses. Here are two examples of cardiac mass evaluation in patients with remote history of treated lymphoma in remission. In the top row, we see a small round mass attached to the interatrial septum that's iso-intense on T1 weighted imaging with elevated T1 mapping, minimal uptake on first pass perfusion, and very mild peripheral LG enhancement. Based on location, size, and imaging characteristics, suspicion was for a cardiac myxoma, and patient did go on to have surgery and resection, which confirmed these findings. In the bottom row, we have a much larger left atrial mass that is iso-intense on T1 weighted imaging with elevated heterogeneous appearing T1 mapping, no significant uptake on first pass perfusion, and also very mild peripheral enhancement on LGE imaging. These patterns, given the size and tissue characteristics, were concerning for a malignant tumor, and patient did go on to have surgical resection, which confirmed cardiac rhabdomyosarcoma. One thing interesting to highlight is the lack of uptake on peripheral LGE imaging compared to the elevated T1 mapping sequence shows what's likely a process of predominant necrosis, and which was confirmed on tissue biopsy as well. I'd like to spend the remainder of our time focusing on where I see the demand and value of cardiac MRI growing the most, and that is into insight into cardiotoxicity, especially with the rapidly growing area of cancer therapeutics. While chemotherapy-related cardiac dysfunction, or CTRCD, traditionally only referred to a drop in ejection fraction, we are now seeing a rapid growth in cancer therapeutics, as well as a rapid growth in various cardiovascular complications that are moving well beyond left ventricular dysfunction. Here is a comprehensive table broken down by type of therapy. In red, traditional conventional cytotoxic therapies. In green, the new evolution of targeted cancer therapies. In yellow, the emerging field of immunotherapy, using our own immune system to fight the cancer cells. And then in blue, other types of therapies, including radiotherapy, which all show different types of cardiovascular considerations to be mindful of. I will highlight a few and show you some of their imaging characteristics to help delineate the cause, as many of these therapies are now used in combination, and it can be challenging to discern which is the culprit agent, if any. First one we'll cover is the most well-known and well-studied, that falls under cytotoxic chemotherapy, which is our anthracyclines, or doxorubicin. We'll also touch on two types of targeted molecular therapies, HER2 targeted therapy, or Trastuzumab, as well as the irreversible proteasome inhibitor Carflyzomip used in multiple myeloma patients. Immunotherapy is where I think the value of MRI is going to continue to expand, especially in immune checkpoint inhibitor therapies, such as pembrolizumab. Once again, these allow your own immune system to fight the cancer cells, and we are seeing a lot of cardiac complications from this. And finally, radiotherapy. As highlighted in our initial CMR protocol that we reviewed at the beginning of the talk, I believe cardiac MRI is not only the gold standard in EF assessment, but also the gold standard to adjudicate the etiology of cardiotoxicity. When we approach a patient with symptomatic decline in their EF or strain, We first start by assessing whether this is a true rise in end systolic volume or if it's a drop in end diastolic volume. And then based on the clinical scenario and type of therapy, we refine our protocol and sequences to broaden our differential and truly come up with the cause and etiology for the decline. Traditional radiotherapy-associated cardiac disease involved effects on the pericardium, valves, aorta, the myocardium itself, and also blood vessels with coronary ischemic heart disease. With modern shielding techniques, some of these risks have been reduced, but we are still seeing ischemic heart disease and diastolic dysfunction in modern therapies. Nevertheless, you will all encounter patients who have had a history of radiation therapy, whether it be in childhood or prior to the development of these newer shielding techniques. And due to the degree of calcification that can form, the initial ischemic evaluation with CT is sometimes suboptimal, and we find that a CMR allows for a comprehensive assessment of these toxicities, with some examples shown of a recent patient with childhood lymphoma and mantle cell radiation, developing symptoms over the last several months, consistent MRI imaging with constrictive heart disease. And on the right, two recent examples, one of an individual who had prior exposure to anthracycline and radiation therapy, again for lymphoma, now with symptomatic heart failure, and findings consistent with radiation ischemic heart disease, as well as below an example of a patient with prior left breast radiation who has now been having exertional fatigue, and a stress perfusion MRI was performed showing ischemia in the anterior and anteroseptal wall, who subsequently underwent a left heart cath showing a high-grade proximal LAD stenosis, which was stented. Anthracycline-induced cardiomyopathy is the most well-studied, and recent advanced imaging characteristics consistently highlight the development of predominantly biventricular diffuse interstitial fibrosis. So it is not common to see late gadolinium enhancement in these studies, and as a traditional cytotoxic agent, appears to get into both the right and left ventricle, causing biventricular dysfunction. The example below shows extracellular volume quantification in a patient without cancer and pre-treatment with normal extracellular volumes of 27% and 25%, and of a cancer patient post-treatment, a 63-year-old woman with hypertension, whose post-anthracycline chemo cardiac MRI showed a mildly elevated extracellular volume of 32%. Here is a recent example of a 37-year-old woman with stage 2B triple-negative right breast cancer with no traditional cardiac risk factors. She received dose-dense anthracycline regimen totaling 240 milligrams per meter squared on April of 2019. No post-treatment echo was performed, and recently, over the past several months, she began developing dyspnea on exertion and ultimately underwent a cardiac MRI shown below. Here you see severe biventricular dysfunction with an RV ejection fraction of 26% and an LV ejection fraction of 21%. Her parametric mapping sequences showed a normal T2 map suggesting no active myocardial edema, with an elevated T1 map and no late gadolinium enhancement. Her extracellular volume was mildly elevated at 35%. Again, consistent what is shown in other studies as well. With anthracycline cardiomyopathy, there is usually biventricular dysfunction, normal T2 mapping, uncommon to have late gadolinium enhancement, and again, diffuse interstitial fibrosis. This case also highlights the importance of always obtaining a post-treatment baseline echo, because what we've learned is the sooner we can catch this dysfunction, if started on appropriate guideline-directed medical therapy, most of the damage can be reversed. In this situation, unfortunately, she is currently undergoing workup for heart transplantation. Next, we'll move on to targeted therapies, with HER2 being the most well-studied and the first in this arena. With regards to cardiomyopathy, the original concerns were from the trials that led to FDA approval, where concomitant anthracycline was given, but overall net benefit favored cancer treatment. Since then, anthracyclines are never given concomitantly, but given sequentially, and a lot of our new therapies are non-anthracycline based when combined with HER2 targeted therapy. The big message has been to avoid interruptions in care. Below is a study which looked at asymptomatic patients with class 1 LVEF declines of 40 to 49% who were HER2 eligible. Of those 31, treatment was initiated with addition of guideline-directed medical therapy, and the majority, 27 of 31, were able to complete their treatments as planned. On the right, when we talk about the harm of interruptions in therapy, this was a recent study published by Memorial Sloan Kettering Cancer Center, which showed that trastuzumab interruptions of greater than 6 weeks led to shorter recurrence-free survival. And this highlights again the point of having a high threshold to interrupt therapy, especially for asymptomatic declines in EF without adjudicating true decline, as well as targeting other supportive strategies that can be done concurrently to protect them going forward. Here is a recent example of a patient I took care of who was a 70-year-old woman with hypertension and stage 3B, ER-negative, PR-negative, HER2-positive left breast cancer. She was on a non-anthracycline-based regimen and had been receiving trastuzumab or Herceptin, now status post 7 cycles. Her screening TTE showed an LVEF decline of 35 to 40%, and her blood pressure at that time was 167/83. A cardiac MRI was performed, which confirmed a decline of her LV ejection fraction to 34%, with preserved function of her right ventricle at 55%. Parametric mapping showed a normal T2 map, suggesting no active myocardial edema, an elevated T1 map without late gadolinium enhancement, and a mild elevation in extracellular volume at 35%, all pointing to diffuse interstitial fibrosis of the left ventricle. And highlighting trastuzumab HER2 cardiomyopathy as likely an indirect toxicity, which usually needs an additional stressor. In this case was thought to be her uncontrolled blood pressure, and we started her on an ARB and beta blocker, and were able to get her back on treatment to the next cycle, and continued on since then with recovery of biventricular function. HER2 targeted cardiomyopathy usually only affects the left ventricle, and again with normal T2 mapping, uncommon to have late gadolinium enhancement with mild elevations in extracellular volume, again pointing to diffuse interstitial fibrosis. Another targeted therapy to mention is Carflyzomip, which is an irreversible proteasome inhibitor, and again, this one is associated with LV dysfunction and hypertension. And similar to HER2 targeted therapies, what we're learning is whether it's HER2 receptors or proteasome receptors, cardiac remodeling seems to be dependent on a lot of these pathways, and disrupting those pathways plus an additional stressor seems to prevent the heart from effective remodeling and likely results in the LVEF decline and occasional symptomatic decline that we see. In the original trials studying Carflyzomib, there was an increase in hypertension labeled in the blue bars, as well as LV dysfunction. But the majority of these were reversible. Relative risk was low and they were manageable. And overall, when looking at the survival curves, the Carflyzomib-based regimens had a much more favorable benefit-risk profile in these multiple myeloma patients, which takes us back again to the goal of the cardio-oncologist to minimize interruptions in therapies. And how we monitor and manage the CV risk is to treat hypertension, especially monitor the frail or elderly patients or those with established cardiovascular disease, and during administration, asking the oncologist to avoid excess IV fluid administration as well. Two recent examples of Carflyzomib-treated patients with multiple myeloma that I've taken care of, both presenting with symptomatic heart failure. In the top row, a cardiac MRI was obtained which showed low stroke volume with a normal EF of 67%, and bilateral pleural effusions with biatrial enlargement. Late gadolinium enhancement imaging showed circumferential transmural enhancement of the entire left ventricle and right ventricle, and the extracellular volume was markedly elevated at 65%, all pointing to high suspicion for cardiac amyloidosis. In the second patient on Carflyzomib with multiple myeloma, a cardiac MRI was also obtained, which showed an LVEF of 70% and a high stroke volume of 79. LGE imaging showed a small prior subendocardial myocardial infarct, and extracellular volume was only mildly elevated at 33%. Her imaging characteristics were actually more consistent with high output heart failure, likely related to the burden of her myeloma in her bone marrow. And more importantly, both of these patients were managed concurrently without treatment interruption and were allowed to stay on Carflyzomib with improved disease response in both situations. I'd like to finish by focusing on the class of immunotherapy agents and their cardiovascular considerations, as they have really ushered in the new era of targeted cancer treatment. And as can be seen below, there has been a rapid explosion in the number of trials and patients that are on not only these therapies, but combination therapies, making the challenge of discriminating the etiology and cause of cardiovascular events more challenging, and where I think the role of cardiac MRI is going to continue to expand, as the balance of stopping treatment versus continuing is going to be more important than ever. The recognition of autoimmune myocarditis from immune checkpoint inhibitor therapy was first recognized in 2016, and the first two patients noted were published in the New England Journal. Since that time, multiple registries have been developed to try to highlight these events, as they are low incidence, about 1% in most registries on a single agent and 2% on combination immunotherapy. However, their morbidity and fatality rates continue to remain high. In the first registry described on the left, what was noted was an elevated troponin, or evidence of myocardial necrosis, was common in most individuals who initially presented with myocarditis. However, an echocardiogram only showed an abnormal EF in 50% of the patients and did not correlate with disease severity. The majority of these patients also underwent a cardiac MRI, where late gadolinium enhancement was noted in 74% of individuals in a pattern suggestive of myocarditis. However, in a separate multicenter registry, only 48% of the individuals were noted to have the presence of late gadolinium enhancement, and the conclusion raised concern about the utility of cardiac MRI. However, the editorial that accompanied the paper highlighted the point that this is a disease process that's highly variable, both in presentation and also in severity, and wanted to do a little bit of a deeper dive into the reasons why the discrepancy between the two studies. What we have learned is the diagnosis of acute myocarditis is more sensitive with the incorporation of our newer parametric mapping techniques, which were not used in the previous study we just discussed. And in looking at the modified Lake-Louise criteria update from 2018, the main criteria now includes evidence of myocardial edema, not just by traditional T2 metrics, but also the newer native T2 mapping sequences, as well as the pattern of non-ischemic myocardial injury that could be not only non-ischemic late gadolinium enhancement patterns, but also an elevation in extracellular volume or abnormal native T1 mapping as well. We could also have supportive criteria with evidence of pericarditis or regional or global LV systolic dysfunction as well. And when looking at the updated criteria, and especially the area under the curve, what we've learned is the combination of parametric T2 mapping with LGE or LGE with T1 mapping seem to be the most sensitive in improving our diagnosis of myocarditis. Here is a case using cardiac MRI with pathology correlation to highlight what we are seeing with the late gadolinium enhancement in these patients. On pathology slide review, the image where the scar is appreciated or enhancement, we see lymphocytic infiltrates, myocardial fibrosis, and also positive staining for PD-L1 as well, again confirming the process of an autoimmune myocarditis. While autoimmune myocarditis was the first recognized cardiovascular complication of checkpoint inhibitor immunotherapy, as registries increase, so do the awareness of additional cardiovascular considerations. 2 recent review article diagrams highlight these and include electrical disturbances from AV conduction block to ventricular arrhythmias, pericardial inflammation, including pericarditis and pericardial tamponade, vascular complications, including coronary vasculitis, as well as acute plaque rupture, myocardial infarction, and non-inflammatory left ventricular dysfunction resulting in heart failure, and a version of Takotsubo syndrome, which can sometimes be very severe and prolonged. What is not known beyond autoimmune inflammation is if all of these clinical scenarios require aggressive immunosuppression, and further prospective registries are going to clarify these moving forward, and why I believe cardiac MRI is best equipped at delineating the exact type of complication so that effective treatment can be given. Here is a case of a patient with melanoma recently started on immunotherapy who presented to me with several days of progressive shortness of breath and heart failure symptoms, and whose biomarker screen test came back positive. We proceeded with an urgent cardiac MRI, which showed biventricular dysfunction with elevated T1 maps, elevated T2 maps of 62 milliseconds suggesting myocardial edema, late gadolinium enhancement imaging showing non-ischemic pattern of enhancement in the septum and lateral wall, and an elevated extracellular volume at 38%, all meeting criteria for the modified Lake-Louise criteria for acute myocarditis, and for which we immediately started pulse dose steroids, and unfortunately patient progressed to cardiogenic shock requiring VA ECMO support and plasmapheresis, ultimately making a complete recovery, but also highlighting the need for urgent assessment, evaluation, and initiation of treatment to improve overall prognosis. Hopefully the preceding examples highlighted the value of cardiac MRI in adjudicating the etiology of cardiotoxicity. As mentioned before, More and more of these therapies are being used in combination, and it is challenging to find the right balance between holding potentially cardiotoxic agents from those that patients are deriving benefit from. As we work down this algorithm, every time we do a full comprehensive assessment with a cardiac MRI, we start learning more and more about the pathophysiology of these treatments and how they affect the cardiovascular system. The traditional radiotherapy effects of the pericardium, the myocardium, and also perfusion, which can all be evaluated in a single test, as well as anthracycline with its traditional cytotoxic effect on both ventricles and the diffuse interstitial fibrosis pattern that is seen without signs of late gadolinium enhancement. Moving on to the combination of targeted therapies discussed, our proteasome inhibitor Carflyzomip or our HER2 targeted therapy Trastuzumab are both resulted from receptor-mediated dysfunction, which usually requires an additional trigger, most commonly uncontrolled high blood pressure, and for which the majority of patients can be kept on therapy and treated concurrently, as the benefits of these therapy far outweigh their cardiovascular risk. On occasion, our scans can also pick up other things that were not intended, such as infiltrative diseases. And immunotherapy is the arena which is becoming more and more important to understand these, while uncommon, cardiovascular events, ones that worsen overall prognosis. Beyond the traditional autoimmune myocarditis evaluation, especially incorporating the updated modified Lake-Louise criteria, we also must be vigilant for ischemic heart disease, pericardial disease, and stress-triggered disease from these treatments as well, as these can be very severe and early recognition is very important. Going back to our comprehensive CMR protocol for the cancer patient, I want you to take away some whys and whens of ordering a cardiac MRI. And the ones that I include today and that we talked about include poor echo images or discordant results, as I would prefer adjudicating an accurate EF assessment before recommending discontinuation or halting of cancer therapies. For the evaluation of pericardial disease and constriction, to evaluate for infiltrative diseases such as amyloid or storage disease such as iron overload, and to the one I think is the most important and the one that's going to have more relevance going forward as more and more combination treatments evolve, is to clarify etiology and pathogenesis of cardiotoxicity, especially for immune checkpoint inhibitor myocarditis. Hopefully, I showed you the value of cardiac mass evaluation, when we can be conservative and when surgical resection is indicated, using non-invasive tissue characterization by MRI. And finally, for simultaneous ischemic evaluation, if working up a new EF decline and considering an echocardiogram plus a nuclear stress test or coronary CT, a single examination can give us all this information, and most exam times now run about 45 minutes. Thank you for your attention this evening, and I will take any questions at this time.